കരുണതൻ നിറവോടെ ഞങ്ങൾ വരുന്നു. കാരുണ്യത്തിൻ നിറകുടമായി രാത്രി മുല്ലകൾ പൂത്ത സുഗന്ധം പോൽ നമുക്കൊന്നായി ചേർന്നിടാം, നമുക്കൊന്നായി ചേർന്നിടാം. കരുണതൻ നിറവോടെ ഞങ്ങൾ വരുന്നു. കാരുണ്യത്തിൻ നിറകുടമായി കനിവു നിറഞ്ഞാടും മാമലനാട്, സുന്ദര കലകൾ തന്നാട്. ജാതിമത ചിന്തകൾക്കപ്പുറം എന്നും മാനവനൊന്നായ നാട്. ഈ നാടിനുയിരായി നീങ്ങാം, ഒന്നിച്ചൊന്നായി നീങ്ങിടാം. ഈ നാടിനുയിരായി നീങ്ങാം, ഒന്നിച്ചൊന്നായി നീങ്ങിടാം. കരുണതൻ നിറവോടെ ഞങ്ങൾ വരുന്നു. കാരുണ്യത്തിൻ നിറകുടമായി നിറദീപമായെന്നും അണയാതെ കാത്തിടും നമ്മൾ. ഒരുപാട് ജന്മങ്ങൾ, ഒരുപാട് യാതനകൾ, അതിലെല്ലാം താങ്ങായി സ്വസ്തി. സ്വസ്തിതൻ കരങ്ങൾ തൻ സ്നേഹത്താൽ നീറുന്ന ജന്മത്തിനാശ്വാസമായി. സ്വസ്തിതൻ കരങ്ങൾ തൻ സ്നേഹത്താൽ നീറുന്ന ജന്മത്തിനാശ്വാസമായി. കരുണതൻ നിറവോടെ ഞങ്ങൾ വരുന്നു. കാരുണ്യത്തിൻ നിറകുടമായി രാത്രി മുല്ലകൾ പൂത്ത സുഗന്ധം പോൽ നമുക്കൊന്നായി ചേർന്നിടാം, നമുക്കൊന്നായി ചേർന്നിടാം. കരുണതൻ നിറവോടെ ഞങ്ങൾ വരുന്നു. കാരുണ്യത്തിൻ നിറകുടമായി ആ
Welcome back to the Kerala Cancer webinar series on Kerala Cancer Crusade and Cancer Literacy Mission. And today is the 4th day of the National IRIA National Preventive Radiology program on cancers. And in this month, today we are going to discuss about head and neck cancers and the early detection. The whole idea of Kerala Cancer Crusade is an 8-year-old mission, 8 years strategy, 8-year-old strategy to downstage the most common cancers in India and Kerala. So as you all know, in males, the second common cancer is head and neck cancer after lung cancer. And maybe if you take the overall incidence, head and neck cancers is one of the major cancers, especially the oral cancers are the major cancers in India. So today we have Dr. Santosh Kumar, a head and neck surgeon, who will be giving us the keynote address. But before going into the academic session, I have the pleasure to invite our chief guest, Srimati Shobha Koshi ma'am. She is the former Chief Postmaster General of Kerala Circle and also was a chairperson of Kerala State Commission for Protection of Child Rights, and is also an advisory board member of the Susti Foundation. This program is in association with IRIA Kerala, Susti Foundation, and the Community Oncology Department of Regional Cancer Center, Trivandrum. So let me invite Shobha Koshi ma'am, our chief guest, to address this August gathering.
Thank you, Dr. Riju, for that for that welcome words. I am really honored to be part of the Kerala Cancer Crusade and Kerala Literacy Missions initiative to promote early detection and to bring down the incidence of cancer in Kerala, which is an 8-year project. I have been also had the opportunity to be involved with the cancer awareness programs in the last 2 years, which were conducted independently. And why I mention that is that each time I come for one of these sessions, I gain a lot of awareness, and it helps me to prepare, because each time I get a different session to be associated with. And this time it is head and neck cancer. So I must say that I am one of the primary beneficiaries of attending this meeting, as I have no technical qualifications on the subject. So what did I learn this time? So I'm just going to briefly touch upon a few things. The first thing I learned was that head and neck cancer is, when you talk about head and neck, you are not including the brain or the eye or the thyroid or the esophagus or the skin of the head and neck. This was surprising to me. I thought everything was covered, but no, we are very specifically talking about throat and larynx and mouth and nose and sinus is what I understand. But with just these aspects, still I gathered that this head and neck cancers account for about, if they occupy the 6th position among all cancers in the world. And surprisingly, 3rd in India, and 30% of all cases in India come under this category. Now, out of this, and that amounts to itself to about 2 lakh cases. Now, out of that, 40% is oral cancer. And that is about 77,000 cases in a year. And this is among the highest in the world. Now, that came as a huge surprise to me. And it accounts for about 1/3 of the overall incidence in the world. Now, most of these cases I gather are among people below 40 years. That came as a shock to me too. And because just think of the loss of human capital and the suffering, because when people under 40 are, become vulnerable to cancer, then it's a matter to be concerned about. And 40% of this incidence is supposed to be coming from chewing tobacco. So, and if you look at the incidence, again, it showed that the largest incidents are in South and Southeast Asia, if you look at the world scenario. But in India, it is primarily the Northeast and those parts of India where tobacco usage, particularly chewing tobacco, is a very high, is very much part of a cultural practice. Let me put it that way. And the sadder part and the good and the bad, I have learned after attending the preventive oncology session and listening to Dr. The director of the National Cancer Institute, pardon? Dr. Rath, say that you have to look at the positives as well as the negatives. Now, the positive part is that this cancer can be prevented, or it can, to a great extent, or that if detected early in the first and second stages, up to 70 to 90% cure is possible, survival is possible. But the sad part of it is that in India, we have not been able to, as yet, reach these levels. And why is that? Why is that? It's primarily because the factors that influence, some of the main factors that influence this kind of, particularly let's take oral cancer, which is what is affecting a lot of people. The issue is that lifestyle diseases, addictive, addictive substances like tobacco, which is both chewing and smoking, as well as alcohol consumption, then lack of oral hygiene and is one thing, then food habits. All of these seem to play a part. Of course, you may talk about viruses like HPV and all that, but a large number of the things that I could make out as a layman are things where some modification of lifestyles can make a difference. This is one thing. The second thing that I noticed was, that I understood is that many of these things, you may see some minor symptoms, you may see symptoms which you may not take very seriously. And because of that, people are coming in, and I read the figure as NCI data, National Cancer Center data says 70% of the people come in pretty late. Now that is something that awareness can certainly make a difference. Now this is where we can play a very major part, and that is what the Preventive Oncology Conference also debated and came to a conclusion. And that is where this sessions that we are having today and in the next few days are going to play a part, because these kind of awareness sessions bring on a common platform all the important stakeholders. There is there's discussion, debate, clarification of ambiguities or concerns that people may have, and then we are able to take this further matter forward. It also helps to optimize resources, because you are bringing in people. We have today people from Calicut, from Ahmedabad, from various places. They are coming forward to contribute. We are also going to have people next week onwards coming in from other countries. So bringing in all these valuable resources and learning from them is a very important opportunity. And then, as Dr. Rijo Matthews said today, these sessions are going to be passed on to others, so that even those who are not present today can benefit from all the things that we are going to learn today. Even it's a dissemination of information to all the other doctors also, that would be possible. So in every way, this is a wonderful initiative. I congratulate the organizers, whether it's the Kerala Cancer Crusade, whether it's the Kerala Cancer Literacy Mission, the IRIA, that's the Indian Radiology and Imaging Agent, IRIA, Swasti, and all the others, and all the doctors who have taken time out of their busy schedules to organize this. And I must point out something. This is actually, October is the breast cancer month, where of course it's primarily women who are concerned. But I'm very happy to notice that you have, as a gender person, I'm happy to see that you have created a niche for a kind of cancer where it is primarily men who are affected, except in Northeast, where I noticed from the National Cancer Center data that 60% are women. But in all other places, it is women have a much lower incidence. So I'm happy to see that you're using this opportunity to bring in the men also and maintain some kind of a gender parity, and to advise, create awareness even among them about what needs to be done. So with these few words, I inaugurate this session. I wish the session all success. Thank you.
Thank you. That was Dr. Shobha Koshi ma'am, the former Postmaster General of Kerala Circle. And she's so passionate about this subject. The last month we had the Preventive Onco Summit. It was a session which had multiple stakeholders coming in together, not only doctors, or all stakeholders involved in cancer care, focusing on cancer prevention. And I could see ma'am spending the whole 2 days attending all the sessions. And such is the passion and compassion she has, and the message she has given us right now. And she has also researched into this. I think Sandosh, she has already, ma'am has already spoken a lot of data that you are supposed to speak. so thank you, ma'am, for joining. Thank you, ma'am, for joining and inaugurating this session. Now we will move on to the academic session. That's a talk by Dr. Sandosh Kumar on head and neck cancer early detection. And Dr. Santosh Kumar did his MS GNT from JIPMER, Pondicherry, and a fellowship in head and neck surgical oncology from Regional Cancer Center, Trivandrum. And he was trained in laser surgeries from Germany and has had professional course. He is a multifaceted personality. Had did this professional course in business management from IIM Kozhikode, and also has authored and published a book, Iruvarinipuriyude Karayil, and scripted and directed a short movie, Kamarunisa, which has won the Special Jury Award from the Nedumudi Venu Memorial Short Movie Festival. And he has got academic publications of nearly 20 national and international publications. So we have a multifaceted, multi-talented speaker today. So let me introduce and invite Dr. Santosh Kumar in to start the academic session. Over to you, Santosh. Unmute, please, unmute.
Thank you, sir. Thank you for the great opportunity. I just finished my 2 long cases were there. The case got finished by 7:15 only. It was supposed to finish by 5 o'clock, but it got prolonged. I just came directly for the presentation. But many of the data or statistics that I am supposed to present already was spoke. Madam has done a good research and presented it well. Okay, shall I share the screen now? Slides? Okay. Are you able to see my slides?
Yes, yes, yes.
Okay.
You can.
Okay. First of all, I'm a head and neck surgeon from MER Cancer Center, working at MER Cancer Center now. Many people, including doctors, doesn't know that there is a specialty called head and neck surgical oncology. Actually, I would like to introduce to you that what all things are included in head and neck cancer. As Madam rightly told, it includes cancer of mucosa of the upper aerodigestive tract. That includes mucosa from lips to oral cavity to pharynx, nasopharynx, nose and PNS to larynx and hypopharynx. Then it also includes salivary glands, thyroid gland, parathyroid gland, and the bone, skin, and soft tissue of the head and neck region. But the pathology, etiology, management of salivary gland malignancy, thyroid, parathyroid, bone and skin, soft tissues are different. So that's why we generally speak about the mucosa, upper aerodigestive tract mucosal cancers that has got a similar etiology and similar staging, similar management. So what is the significance of presenting head and neck cancers here? Especially that a platform that aims to prevent or prevent cancer or aims to have an early detection of cancer. It is the 5th common cancer worldwide. Some of the books says it is 6th, it is 5th and 6th, most common, it is 5th most common cancer. About 25 to 37.5% are diagnosed in Indian subcontinent. Compared to that, the Indian subcontinent includes India, Pakistan, Afghanistan, Bangladesh, Sri Lanka, this belt. But the thing is, we should compare this data with the Western countries or developed countries. The incidence of head and neck cancer is less than 4%, whereas in India it contributes almost 1/3 of cancer burden in India, while it is in US it is less than 5%. So the importance is, in spite of all the development in the cancer treatment, diagnostic facilities or the medical facilities has improved, but the 5-year survival rate is still around 50%. the main reason for the decreased survival rate is most of the head and neck cancers are diagnosed at an advanced stage. As Madam rightly told, 70% present in either stage 3 or stage 4. Then the survival also decreases. The 5-year survival, the cancer, as you all may be knowing, usually the survival, especially for the cancer survival, is usually defined, or we usually spoken in terms of 5-year survival, or the aggressive cancers are 2-year or 3-year survival. The usual term is 5-year survival rate. So early cancer, whether in head and neck cancer, if 5-year survival is more than 90%, and it gradually comes down to 20 to 40% for stage 4 cancer. That's the average. It comes around 50%, 40 to 50%. That is the this rightly point out why we should have awareness among the people for the good prognosis of the, or to cure head and neck cancer. And another significant point is most of the head and neck cancers are preventable. That I will come to. I have put the slides on etiology. That's why we can there we can see these head and neck cancers. Most of the head and neck cancers, except for the thyroid or salivary gland cancers, are preventable. And unlike GI malignancy or even lung malignancy, early detection is easy because the signs or the symptoms we can feel. The symptoms people can feel it early or can see it early, or that will come out relatively easily. But still, it is the people present at an advanced stage. And another thing is another important thing is the head and neck cancer mainly affects low socioeconomic group. And regarding presentation itself, there is a difference. I have worked at JIPMER, which is a central government institute, where mainly the low socioeconomic group are coming, and RCC, which is mixed, heterogeneous group is coming. Malabar Cancer Center also I have worked, it is also mainly caters low socioeconomic group. So in a low socioeconomic group, what I have observed, this is not the data from the data which is published, but what I have observed is from the low socioeconomic group, mainly it is addictions. But in a cancer center where I am working right now, is mainly caters middle income group. The extreme low socioeconomic groups and the high socioeconomic group are extremes here. But here the presentations are relatively earlier, but whoever is presenting here at an advanced stage is mostly due to either they have neglected or they might have gone to other treatment modalities, alternative treatment. That also point towards the lack of awareness. Mainly they are going to alternative treatment mainly because they are afraid of cancer. They are afraid of cancer treatment. People think about cancer treatment. First word that comes to their mind is chemotherapy, loss of hair, or the surgical morbidity. That's what I have observed. I told you most of the head and neck cancers, especially the oral malignancy or throat cancer, are preventable. The main reason is the etiology. As Madam also rightly pointed out, that 40% of head and neck cancers are due to tobacco. So in India or Indian subcontinent, why most of the head and neck cancers are diagnosed? The main reason is tobacco. There are around 70 different carcinogens present in tobacco. So either they are used, tobacco is used as a smoke or smokeless tobacco, but whatever be the method. Here they also add, India in Kerala also famous for using betel cubed. Betel cubed contains betel leaves and the areca nut also. Both uh, adds to the there is synergistic or additive effect to the carcinogenic potential, and that's why main subsite was bucco-alveolar complex. Because of these addictions, now it is gradually changing to tongue is the one of the most common oral malignancy. From the bucco-alveolar complex, it's gradually changing to the tongue. And the next common thing is alcohol, and tobacco plus alcohol is a common thing, especially in Kerala. I'll just add the tobacco is not just synergistic, or tobacco and alcohol not just synergistic or additive. It increases the cancer risk multiple times. It's a usual habit that take alcohol and have a smoke after that. This is very increases the carcinogenic potential, because I early told that around 70 carcinogens are there, but all that are not aqueous soluble, but many of them are soluble in alcohol. So with those whichever carcinogens were not soluble in aqueous or in saliva are also solubilized by the alcohol, and that will invariably lead to the absorption and can cause cancer. And alcohol decreases the DNA repair activity of the DNA repair enzymes, and it impairs the immunity by reducing chronic alcoholism. That impairs immunity by reducing T cell number, decreases mitogenic activity and macrophage activity, and of course in the old biochemistry you might have learned one of the first byproduct of alcohol is acetaldehyde, and we Indians have got are a group of population with different levels of deficiency of aldehyde dehydrogenase. So that's why this acetaldehyde will accumulate, and acetaldehyde is another potential carcinogen. And this alcohol will contain other non-alcoholic constituents, especially indigenous or even other things also, which is that has got carcinogenic potential. And alcohol directly causes local mucosal damage, or due to the vomiting or the GAD following alcohol causes local mucosal damage. That also increases the absorption of the carcinogens. And chronic alcoholism is another cause for malnutrition. That also increases the cancer potential, and it upregulates the enzymes of cytochrome P450, leading to the activity of procarcinogens to carcinogens. And regarding viruses, it is an upcoming only 40% is due to tobacco, but there are the rest 60% is not due to viruses, but HPV is one of the leading or increasing. The head and neck cancer due to HPV is increasing nowadays, especially in developed countries. India, we don't know the exact statistics, because and another thing is HPV, human papilloma virus, is mostly documented evidence we are having with oropharyngeal carcinoma. In USA, 75% of oropharyngeal malignancies are due to HPV. That may be due to their sexual habits, including multiple sexual partners and oral sex, etc. But India, we don't have the exact data. HPV, all of you might be knowing HPV is the reason for CA cervix primarily. So oropharynx we have got data, and but HPV related oropharyngeal malignancies are better prognosis, has got a better prognosis, and that's why there is a de-escalation. Only now it has got a different staging system, and that's why de-escalation of treatment also started. And HPV, during biopsy we used to routinely check for the HPV. HPV means P16, that is the tumor marker for HPV. And Epstein-Barr virus is an etiology factor for CA nasopharynx. CA nasopharynx is more prevalent in the Hong Kong and China and our northeast in India. And unless otherwise posed, it is mainly due to Epstein-Barr virus. And HIV is, the prevalence of HIV is decreasing, but HIV is a cause for any malignancy, but oral head and neck cancer also HIV causes. And not only HIV, any immunosuppression can cause cancer. Other thing, immunosuppression, including after post-transplant patient receiving immunosuppression for long period of time are presenting with cancers, and some other rheumatoid means immunological conditions also has got those who are on immunosuppressant. Long-term chronic immunosuppressants suppression is a cause for malignancy. And malnutrition and dietary factors. It is we will usually talk about malnutrition because so many deficiencies can cause the DNA repair enzymes inactivity and all. But increased this obesity and increased calorie, increased protein things can also cause malignancy. That is usually an unaddressed thing, which is more common in of course you all know that head and neck Kerala is capital of diabetes and other metabolic conditions. So this oxygen free radicals and nitrogen free radicals are abundant in those with obesity and other metabolic conditions, and that is also a cause for head and neck cancer and other malignancies also. And radiation is supposed to be a cause. That is, radiation means it's not the therapeutic radiation, but it is supposed to be extraterrestrial radiation, which is not very common. But in Kerala, seashores are supposed to have extraterrestrial radiation. But a study done by RCC, Regional Cancer Center in Karunagapalli and Kollam area, has negated this hypothesis that we don't have any increased incidence due to the extraterrestrial radiation of the shores. And chronic irritation or trauma due to dentures or ill-fitting dentures or teeth can also cause head and neck cancer, oral cancer. These are some of the seeing some of this list. You can understand why head and neck cancer are preventable, why it is only less than 5% in USA or European countries, and why it contributes to almost 1/3 of cancer in India or other Indian subcontinent, other developing countries. And many people usually will ask you, oh, so many people are having tobacco, but not all are having malignancy. The answer is there is something called tobacco associated susceptibility or tobacco associated gene. And if suppose a family member is having a cancer related with tobacco, suppose whether it is lung or oral malignancy, they have got a potential 2 to 14 increased chance of having a malignancy if they are using tobacco, only if they are using tobacco. So that also shows how we can prevent it. And other genetic factors or familial factors are some of the DNA repair enzyme defects or other conditions like xeroderma pigmentosum, Fanconi's anemia, ataxia telangiectasia, Life-Romaní syndrome, hereditary non-polyposis colorectal malignancy cancer. These conditions has got increased potential. And we have got view of, there are so many occupational risk factors. Woodworkers has got increased nose and paranasal sinus malignancy and other things. Formaldehyde, this not only head and neck, other things also, other cancers also these things causes, but head and neck or upper digestive tract is directly exposed to this. Alcohol manufacturing, leather workers, nickel refiners, radium dial painters, paint and printing, textile workers, chromium, asbestos, rubber fumes, sulfuric acid, metal workers, plastic, car mechanic, coal, naphthalene. These are there is increased potential. That's what it is termed. And alcohol and tobacco that I use. And there are almost 9 lakh cases are diagnosed every year and 4 lakh deaths annually. Oral cancer is more common in Indians. I told you, CNS is common in Hong Kong. Some of the interesting facts: male-female ratio varies from 2:1 and varies between 2:1 to 15:1. But it is in India it is 3:1, I think. And but the cancer, head and neck cancer or oral cancer in females are increasing nowadays. This especially those associated non-tobacco or non-alcohol associated head and neck cancer is increasing in females nowadays, especially in younger ages. We don't know the exact etiology for that. And highest incidence in males is in a place called Sommet in France, and females it is Bangalore. Lowest incidence in males it is Ecuador, and females is Korea. And we are focusing on early detection and prevention. And many of the head and neck cancers starts as pre-malignant lesions. So if we closely follow up these or see the oral cavity or tongue or whatever it is, some of the I'll like to introduce you some of the pre-malignant lesions. This is leukoplakia, that is white patches which is seen in oral cavity, and these leukoplakia has got a 5 to 10% potential to become malignant. So if it is small, you can excise it, or if it is diffuse, it won't appear suddenly as diffuse. Only in chronic tobacco chewers it usually appears as diffuse, or before that itself. Otherwise you can diagnose it early. So you can either closely follow up or you can excise it earlier. And this is erythroplakia. Erythroplakia has got any much more increased potential, 10 to 15% of chance of malignant potential is there. And submucous fibrosis, that is mainly due to the tobacco. This is among the pre-malignant lesions. Submucous fibrosis has got the maximum malignant potential, and usually people will have present with the trismus, different grades of trismus. And this is another thing, lichen planus. And keratosis is a condition like white patches similar to leukoplakia in oral cavity. It is usually seen in larynx, and usually when keratosis is there will be some kind of voice change, not typically hoarseness. It can be, there will be a hoarse change. So either you can have a biopsy, or you can follow up these things with regular endoscopic examination. And for the pre-malignant lesions, the treatment is actually stop the etiology. If there is an etiology like tobacco, alcohol, whatever the etiology, first and foremost thing is stop the etiology. And excision, if possible, excision is possible, you have to excise it. And carbon dioxide laser is the preferred thing, or even usual as usual surgical or electrocautery can be used. Other option is watchful waiting for the compliant patients who are not ready for an excision. And if it is diffuse also we cannot excise it, then in such cases we can uh, biopsy the suspicious areas. And to find out the suspicious areas, there are different techniques like dyes can be used. There are different lights like veloscope, infrared lights can be used to detect the suspicious area when there it is diffuse, from where to take the biopsy. And here are some of the signs or symptoms that one should be suspect. When should I suspect? It is most of the malignancies in head and neck cancers or oral cavity starts as a non-healing ulcer. Non-healing ulcer is defined as if an ulcer is not healing even after 3 to 4 weeks in spite of treatment. I repeat the word in spite of treatment, because some of the aphthous ulcer or some of the traumatic ulcers may not be healing if you are not taking any treatment. But any ulcer which is not healing it spontaneously, the concerned or the patient or the people should consult a doctor and get it treated. If it is not getting relieved after 3 to 4 weeks, we should take a biopsy. That is the indication for biopsy. Most of the malignancy starts as a non-healing ulcer. And another thing is swelling. Swelling can be in any area in the head and neck area, either in the neck as lymph nodes, or thyroid as will present as a swelling, parotid or salivary glands will present as swellings. Even the nose, PNS malignancy is present as swelling. Swelling also usually it will be painless swelling. Usually, as all of you might knowing, painful swelling is usually due to the inflammations or infections. So usually painless swellings. And if it is persisting for more than 3 to 4 weeks, or it is increasing in size, you have to go for a tissue diagnosis. Usually for swelling, we used to take FNAC. Then imaging can also be considered if you are suspecting it. And pain. Pain is one of the symptom of cancer. Pain usually associated with a deeper infiltration or bony involvement. Some of the cancers, even head and neck cancer, has got some hidden areas, and such cancers usually presents with pain. The base of tongue is an area which is not easily seen outside, but base of tongue, any malignancy usually will have severe pain, because whenever we are having food, whenever we are having trying to speak, when the tongue is moving, it will cause pain. I know there are many patients, but there is I know one patient recently, 2 months back, he came with pain. He used to complain of pain on one side of the neck and head, and he has gone to many of our specialists and super specialists for last more than 6 months, and they have treated him with many multiple analgesics, including neuropathic things, but nobody has managed to I don't know whether whether even if base of tongue is, you cannot see on just saying or just opening the mouth. You need to palpate, because other things usually will have an ulcer or a proliferative growth, oral cavity, but the base of tongue will present with a ulcero-indurated growth. So, and there are multiple follicles also, lingual follicle, normal lingual follicles also. Usually, and most of these malignancies can be appreciated only on palpation, and or it will present with the lymph nodes, and that patient presented with an stage 4 severely ankylosing conditions. And another patient presented with pain. Pain that also usually people cannot localize it, only that side they will tell. And actually there was no mucosal disease, but on imaging there was a lesion in the petrous apex and skull base, which is coming to infratemporal fossa, a large lesion from involving the petrous bone and skull base. Okay, so pain is also one unexplained pain, which that's what we can say. And loosening of the teeth. Some of the early cancers will lower alveolus will present with the loosening of the teeth, and those who are using dentures suddenly they might have been using it for years, but now it is ill-fitting. Then usually that is a cause for means malignancy usually causes an ill-fitting dentures. And regarding the throat, change in voice, usually a small change, even a polyp or a vocal nodule, any change in the mucosa of the larynx can cause, vocal cord can cause a change in voice. So, but a change in voice need to be evaluated if it is persisting for more than 4 weeks. So a LRA or a URA can cause change in voice, but usually that can be managed with medications and will get relieved in another 3 to 4 weeks. If it is not getting relieved, you need to check for video laryngoscopy or laryngoscopy, and usually we have to find out the reason. And even in oropharynx also there will be change in voice, but it won't be as marked as oropharynx or hypopharynx also. It won't be as marked as the larynx. There will be difficulty in swallowing. That is a symptom of difficulty in swallowing or a foreign body sensation. Initially, hypopharynx and oropharynx, it's like a junction. Oropharynx is like a junction, so there is a lot of space. So the difficulty in swallowing will appear only in later stages, but initial symptom will be a foreign body sensation of the throat. And nasal obstruction, regarding the nose, it can be nasal obstruction or chronic epistaxis or serous otitis media. The CA nasopharynx can present like otitis media, earfulness, okay, earfulness or tinnitus, something like that. For cervical lymph node enlargement is an etiology, especially CA nasopharynx or CA hypopharynx or even CA supraglottis can present with the cervical lymph node enlargement. And cranial nerve palsies. Cranial nerve palsies can be due to, especially skull-based malignancies can present with the cranial nerve palsy. There won't be any other sign or symptom but cranial nerve palsy. And early cancer, regarding just I will just show one picture of the early this tongue cancer, which is this stage 1 early cancer, and usually even before this itself, half the size or before this itself, we can actually suspect it and go for a biopsy. And this is one of the advanced cancer, and this is mucosa covered. Usually this salivary gland malignancies or minor salivary gland malignancies like adenocystic carcinoma, mucoepidermoid carcinoma usually present like this, and in such cases we can do FNAC, and a biopsy may yield only the mucosa, but FNAC can usually diagnose it. And I'm not going to in detail for the treatment regarding the treatment, but the as a part of workup, first we need tissue diagnosis. If you are suspecting a malignancy, that is either can be due to the biopsy by the biopsy or FNAC, then we need to do first tissue diagnosis, then we need staging. Staging can be done with imaging. This needs to be done with imaging, depending upon the clinical stage of the disease. We can go for ultrasound neck, CT, MRI, or even PET scan in later stages. And endoscopic evaluation is also required for almost all head and neck malignancies, because second primary or synchronous primary is also common with head and neck cancer, because usually as we told, tobacco users has got are 40%, 40 to 50%, or 40% of the cancers are due to tobacco. So tobacco can cause field cancerization. Field cancerization means there are multiple pre-malignant lesions or cancer-prone areas. So there are incidents. Patient can present with the synchronous primaries, primary at multiple sites. So endoscopic evaluation is required. Regarding the awareness or lack of awareness of the cancer, I just want to mention some of the people are aware, or even for if you conduct a medical camp, there a lot of people will attend. Okay, there will be there will be much crowd for that. Even people will come with that pain, this pain. But if you are conducting a cancer detection camp, the only very few people are attending such a cancer detection camp. That is due to there is a psychology also, I think, because even many people are not ready to evaluate it, some of the signs or symptoms that they are having, because if it is cancer, that's what they are thinking. So that is people, it's not, many of them are afraid of cancer, because after 2000, I think I can say after 2000, the treatment of cancer has changed a lot, and we now have about 70 to 80% of the cancers are potentially curable. Only thing we need, they need to present at a early stage. But people are usually afraid of cancer. That is mainly due to, see, at least people of 40 plus people are having some memories of their relatives or neighbors having cancer in an era where cancer means death. Okay, or that might be a truth before 2000, or 2000, because they might have seen that tragic situation. So that is one of the reason for their fear. And another thing is this regarding the morbidity or the chemotherapy. Chemotherapy means people doesn't know there are so many chemotherapy means people, many of them are having an idea that chemotherapy means it's a one medication, and okay, they don't know that it is different medications, or it is whatever be the chemotherapy, you lose hair, and that's what many people are thinking. So awareness regarding such things are required. And nowadays many people are there who are utilizing these situations, whether it is accepted medical branches, or this Nadan Chikitsa, this thing, but there are so many people who will blindly recommend. See, once cancer is diagnosed, so many people are coming for coming to people with different opinions and suggestions, and even some of these people are becoming vulnerable to such suggestions, even if they are not willing. I have seen people, uh, and another thing is, this has got nothing to do with education. Education doesn't have any role in such things. That's what I understood, because I have seen or treated a person who is an engineer who has done an MTech and was working, and he has gone for ozone therapy. Ozone therapy is a newer thing that's in some Pollachi. Okay. And see, an MTech person is, or BTech or MTech person, he should be knowing what is ozone and all. So, and many of the people who are going for, means, I don't know whether now I'm working in a hospital where mostly middle income group are coming, and most of them are usually educated people. Educated means at least they have got minimum education. And recently I saw a science teacher who has gone for alternative treatment, presented with the advanced oral cancer. His two children, sons, one son is doing a PhD in IIT. Okay, another one is also well educated from another central government institute, and science students. That's what they are also science students, and that's what I just wanted to tell. It has got nothing to do with lack of awareness, has nothing to do with education. Okay, it is maybe a way that may be changing with okay, with time. Okay, thank you.
Thank you. Thank you, Dr. Sandosh, for highlighting the early warning signs and giving us the statistics on the head and neck cancers. So one of the aims of Kerala Cancer Crusade and Cancer Literacy Mission is to, as I already mentioned, is to have identify people at very early stages, and even work out even people with high risk. The high risk groups also has to be identified. And how can we do that? With the help of the doctor community, as well as using the paraclinical and the other multiple stakeholders in cancer care. This is what the Kerala Cancer Crusade is looking at for the major cancers in Kerala and all over India. I have in the panel Dr. Diva Shah, is a radiologist from HCG Center, Ahmedabad, and Dr. J. Krishnan is an additional professor in the Community Oncology Department of Regional Cancer Center, Trivandrum. So let me ask Dr. Diva this question. Imaging, as Dr. Sandosh has mentioned, plays a role in staging. But what are the early imaging biomarkers that we can detect with the help of imaging modalities like ultrasound, CT, MR, or whatever modalities that we are using? Do we have some early imaging biomarkers that points towards early detection and that can help in the diagnosis of in downstaging the disease?
In our department, our major patients are of head and neck cancers, because of this is a tobacco zone. And frankly, I would like to tell you that the clinicians, the ENTs, the dentists, maxillofacial surgeons, patients usually goes to them first. And we should have, we are just, can say, adjuvant to them. So in my experience, primarily we cannot detect, say, like there are values of the modality, say to detect the submucosal fibrosis, to detect the pre-malignant conditions. But it needs, we need first of all, thorough clinical examination. So most important that the tobacco chewers, or they should have a regular interval oral examinations with their dentist or with the oncospecialist. And as a radiologist, we have to see the neck ultrasound, which helps to detect the abnormal neck nodes. Sometimes this is the common presentation of the oral cancers, where the cancers are very small in size, but they presented with the neck swelling, neck nodes. So this should be addressed, and this is how we can help them. Second thing, in my experience, see, we are doing routinely MRI of all these patients. Not in a known cancer, even if they have a leukoplekic patches, we do MRI. Now in this MRI, don't go for long examination, don't go for contrast examination, but just acquire the MRI sequences with some maneuver. Say they see the oral examination either with open mouth, so do that open mouth techniques, do puffed cheek, ask the patient to blow so that the entire vestibule gets distended. You see small thickening, and this is how you can help your clinicians. So these are the ways where you can detect early changes in the mucosa, which has been happened because of the chronic use of this tobacco.
So what Dr. Diva has rightly pointed out, a lot of imaging studies are being, especially ultrasound of neck for thyroid, for maybe any swelling that is being done. In a routine basis, there are so many examinations being done, but it's high time for radiologists to focus on the early imaging biomarkers, especially with respect to nodes that can be an early clue for further investigations and detection of early cancers. And as she has rightly pointed out, the MRI also plays a role. CT also plays a role. Maybe even if it is done for some other purposes, there are some early imaging biomarkers that can help us to detect head and neck cancers at a very early stage. Let me go to Dr. Jay Krishnan, the community. Yeah, Dr. Sandosh, you have got something to say on this.
I just want to say, actually, in early detection, radiologists play a role mainly for the thyroid cancer. Yes. Nowadays, the incidence of thyroid cancer is increasing. That is mainly due to the ultrasound. At least according to US statistics, 25% of the thyroid cancer is detected ultrasound. Correct. Even without a mass.
We have a cancer screening module in our department. So in that cancer screening module, we do ultrasound of neck, abdomen, pelvis, and for female we add the mammography, and for male we add the serum PSA and all those blood investigation. So we do ultrasound of neck in each and every cancer screening patients to see thyroid and neck nodes mainly. This is our cancer screening program for patients who even do not have any complaints.
So what are the high-risk groups that we need to focus for this imaging modality? So Dr. Sandosh, what are the high-risk groups that you will be targeting in the case of head and neck cancers? Because mass screening is something that is very, very difficult from the point of view of a population that we have in India. But it is high time for us to look at high-risk group screening for cancers. In that case, for head and neck cancers, which are the high-risk group that that we need to focus?
Without any risk, I can say it is tobacco on alcohol users, chronic tobacco and alcohol users. But it is also difficult, especially in Indian scenario, it is difficult. But actually, Dr. Jayakrishnan can tell in a better way, because Trivandrum, RCC is famous for their early cancer screening programs, which is published, 5-6 papers has been published in Lancet and such journals. That was done in early cancer detection of the oral cancer, because they used to continuously, what they did was they did a community screening first, and they identified high risk group, and those high risk group were screened in regular intervals. So means those with premalignant lesions or those that are at high risk group, and if we can go to them and or make them come to us and screen them, identify the high risk group and then screen them at regular intervals is the best thing, best option. That is
Yeah,
not with
Dr.
an imaging, but
Yeah,
as
right.
Dr.
Yeah.
Divya showed.
Dr. Jaykrishnan is here. I think RCC Community Oncology Department has done a significant work on this particular area, head and neck cancers. Jaykrishnan, I just want to ask you, one point that Dr. Santosh has highlighted is whenever we organize a medical camp, without a general medical camp, there will be a lot of people who will be joining just for pain and all these things. The moment it is a cancer screening program, the numbers come down significantly. People doesn't want to come for such a camp. So in that scenario, how can we identify this high risk group and then subject them for a screening program for most of these cancers, especially for head and neck cancers? What are your thoughts on it? And as part of the Kerala Cancer Crusade, how can we implement such initiatives?
Oh, thanks, Dr. Rijo. That was a good question. And so, first of all, I would like to share some of the ideas regarding screening. So, because we are working in the community oncology department. So, what I want to say first is that when we talk about early detection, it has got two components. One is the screening component. The other one is the diagnostic evaluation component. So, just now the speaker, Dr. Santosh and Dr. Divya had mentioned. So regarding the diagnostic evaluation part, I think these are the areas where we have to give more importance, like in terms of investigations, like that. But for screening part, again, there are a lot of confusion regarding where we have to implement the screening part. So when we talk about oral cancer as such, I think we have to find out the high risk group. So, like instead of going for a random screening of the people, that is wastage of resources, we have to concentrate more on the high risk groups. So, in RCC, what we have written, we have done is that under the able leadership of Dr. Shankar Narayan, Dr. Ramdas sir, and Dr. Babu Mehta sir. So, what they have done was that was a randomized control study which was done in the community development blocks in Preventive district. They have identified the high-risk groups and in that blocks, and so what they did was they trained community volunteers. So they were actually not medical. They're not having a medical background. So what they did, they trained community volunteers. That was a huge trial, and which was conducted with the support of the IRIA, International Agency for Research on Cancer. And what they found was that if you do screening using community volunteers, trained community volunteers, because they trained those people on understanding the types of lesions which occurs in the oral cavity, like the white lesions or mixed and white patches growth, things like that. So proper training was given. And what they found was that if you do an organized screening program in a high-risk group, that was found to be effective and successful in decreasing the mortality due to oral cancer. Instead of doing like just like going for a screening program. And that's why most of the developed countries, even they don't insist for a screening program as such, but they have already mentioned that you have to do it in a high-risk group. And that's what clearly the National Health Policy of 2017 had pointed out, that an integrated approach. That is, you have to have an integrated approach for screening, and you have to integrate with the primary health system network. With the help of that, you can have downstaging of cancers, particularly oral cancer. So I think the need of the hour is to train, community. Community volunteers. We need skilled navigators for that. We can train various groups like the NSF groups, or even the health workers, try to train them and do the screening part. That's exactly what now the Kerala State Health Service Department they are doing. So like the using that app, that Shaili app, they have trained ASHA volunteers with a set of questions regarding various cancers like oral versus cervical cancers, and then going to the household visits, and they are asking questions, and based on that they will be channelizing the particular person to the nearest health center. So that's the process. I think we have to adopt, and that is more cost effective. I mean, rather than going for a generalized screening program.
So the high-risk group screening is something that has to be practiced and that has to be focused. But then training of these volunteers, either as part of healthcare paraclinical team or the trained volunteers for a specific lesion, looking into specific lesion, is something that has to be integrated if it truly wants to reach out to make an effective screening program. But then let me ask you here that doctors, in the sense dental surgeons, the ENT surgeons, and many of the even the general practitioners, are we not missing a great opportunity in this cancer screening program? Even the radiologist, as you rightly said, the increased detection in head and neck cancers, thyroid cancers, are due to the increased use of ultrasound for neck that has come out last 10 years in a very big way. So are we not missing an opportunity here without having a screening, cancer screening protocols integrated into our practice, in the sense we just see it for the particular illness with which the patient is presenting, but then we may be missing out an opportunity to look for early detection of cancer. So isn't it high time that we need to integrate this into our practice of various medical specialties? Your take, Dr. Jayakrishnan, Dr. Santosh, and Dr. Diva on this.
Absolutely. I think there is no doubt about it that we have to integrate these things into the primary health settings. And we need a combined approach, like a multidisciplinary approach. It's a teamwork. As far as cancer treatment or cancer control is concerned, it's a teamwork. When you talk about the cancer control component, it has got so many factors like the prevention, primary prevention, early detection, treatment part, rehabilitation. All those things will come into come into the scene. So what I say is that even if we talk about health as such, most of the determinants of health lie outside the health sector. Like tobacco. So we need effective tobacco policies and alcohol policies. We need nutritional policies. So, and we have to engage many other departments also in the primary prevention part. I'm talking about the primary prevention now. And regarding the early detection component, again, we have to talk to dental surgeons. We need to retrain these people again, and so that the whole idea is to minimize the screening interval or the time of first contact with the doctor, and then getting things done like a diagnosis part. And once it is diagnosed through a biopsy, and then going for the treatment part. So that's the way of downstaging the cancer. I think we need a protocol-driven approach, and for that, it's like a combined approach, which requires both the primary prevention leaders and also the secondary prevention leaders. Of course, so dental surgeons, ENT surgeons, even radiologists, as you rightly pointed out, we all have got a major role to play. And it's really high time to do it, because even now, still we are talking too much about oral cancer, but still we are not able to figure out what is the best possible solution. But we have it in our hands. We know what are the risk factors. We know what to do. It's just to act upon now. And we need like in our Kerala Preventive Summit, in which we have discussed various factors. It requires a combined, comprehensive approach, encompassing both primary prevention and early detection and treatment.
Yes, Jayakrishnan, and one more thing that I wanted to highlight here is some of these precancers or some of these risks are part of habits and addictions. So isn't there a role for a positive transformational programs that has to be associated with this campaign? Otherwise, just screening alone for early detection? Will it serve the purpose?
No, I think, as I mentioned earlier, we need to focus more on the on those risk factors, like the primary prevention approach. You know, if you look at the tobacco use, India has got 26.6 crore tobacco users. It's a huge number, and smokeless tobacco, everything is there. And even in our state also, if you look into the data, we can see that most of the cancers occurring among men are tobacco associated. Even we are talking about a 100% literate state like Kerala. So we have to be a role model for this. We have to find out mechanisms through which we can control head and neck cancers, particular or other tobacco-associated cancers, where we have to train people, and then we have to move accordingly.
Yes, Dr. Sandosh, your take on it.
Regarding the screening, that's I told you earlier, it's a mass screening for a head and neck cancer detection is not that easy or possible.
Yes.
So, like RCC did, we can identify. What we can do is locate a region, either a panchayat or a 2 or 3 panchayats, and detect high risk group. And this screening is not a one episode thing. It should be a continuous thing, either 3 monthly or 6 months. Once you identify the high risk group, you have to screen them at regular intervals.
Right.
Because high risk group they don't need any treatment. You can actually make them stop whatever the risk factors and all, but still they are not free of the disease. A chronic tobacco user, suddenly today they stop, is not free of the risk factor, right? So we need the continuous screening. These are all some of the limitations or obstacles. That's what I am telling. Another thing is, see, you are monitoring a high risk patient or high risk person continuously, and you detected a cancer, okay, at some point of time. Then once after screening, I detected a cancer, I cannot tell that, yeah, okay, you have got cancer, go and treat from somewhere. Okay, so I should have the backup to treat him also. Once I am going to him, he hasn't come to me. I have gone to him and I have found out a cancer in him. So I should be able to offer some treatment. That is not possible in a private setup or without a cancer, means without a program, without a support, financial support. So that is another limitation or obstacle in front of people like us. Okay.
Okay, I got that point. So,
Can I add on?
yeah, Krishnan.
Yeah, I think what Dr. Sandosh told was that, I mean, once you detect pre-cancer, and we need to follow, because if it is a cancer, we have a treatment protocol and we can go accordingly. But as far as pre-cancers are concerned, if we are diagnosing it, it's our responsibility and duty to follow the patient, which is not that easy, because we really don't know when it can change into malignancy. There are certain cases which won't change it, because most of the cases will be harmless. I mean, like, it won't turn into malignancy like that. But there are certain, certain pre-malignancies which can turn into malignancy, and follow-up is a crucial component. And that's exactly what the health service department are doing right now. So, it's a decentralized, healthcare system. What they're following is that once you detect these pre-cancers and all, it is better to channelize these people to the nearest family health center or primary health center, where they can undergo follow. And if they find it that they need the kind of treatment like a laser or some other excision of the total lesion, they can go to the next level. So monitoring is very important, and I think Dr. Babu Master always say, it's a poor man's disease, mostly oral cancer, as far as oral cancer is concerned. So when we talk about oral cancer as such, it's always better to channelize the person to that nearest center where they can go for an active follow-up, and from there they can go to the next level.
Before we wind up, I've got a question to Diva. Diva is from Ahmedabad, and the tobacco chewing is very common in that part of the nation, compared to Kerala, I feel, especially the. So, what are the kind of lesions that you? What are the incidents that you see? Is it very high when compared with other parts of the country, or what is the incidence in Gujarat on this?
So the pattern of malignancy for oral cancers are a bit different than for the west zone from the north. I have seen that in north we are getting a lot of base of tongue cancers. If we talk about the oral cancers, which is related to HPV status, while in here we see the oral cancer which affect the oral vestibule. The most commonly affected site is RMT, the retromolar trigone, because the tobacco part they chew and they put it here in one side of the mouth. So that is very common. We are seeing a lot of pre-malignant conditions now on our investigations also. Dysplasias, which has some different features, although we cannot truly differentiate, but at least we can say that this is something going abnormal than the routine mucosa. We are seeing verrucous hyperplasias also, where we are seeing large tongue lesions and tongue or oral cavity lesions. So this is the pattern which we are seeing. We are seeing also small ulcers with a large neck node. They presented usually with, and to our surprise here, there are two young patients. Like we are seeing these cancers in the younger age groups. We are seeing in the age group, it starts from the nearly 18 years, 16 years we are seeing, because they all are having the habits of tobacco chewing, and not just males. Here the female also chew tobacco. So these are the pattern we are seeing commonly. So it is more of an oral tongue, oral vestibule than the base of tongue here. Right. So that is the pattern. Yeah, and in case of thyroid cancer, we have a screening program here, and I have seen that it is common. We are picking up in the females because it has some relations at times with the hormonal status, and we are seeing some well-differentiated thyroid malignancy, small, which is less than 10 millimeter in a female post-pregnancy or around the. So this is also we can pick up.
Right.
Ultrasound.
They are papillary carcinomas?
Yes, they are papillary carcinomas.
Right. Okay. So our chief guest is still with us, Shobha Koshi ma'am. Would you like to have some comments on the program?
Can you hear me?
Yes, ma'am. Yes.
That's been a very fascinating information. When I tried to read it, because I couldn't understand much of the technical words and all that, I had a lot of doubts, but I'm happy to hear Dr. Santosh Jose's presentation helped to make me understand that better. But what really fascinated me is Dr. Jayakrishnan's talk about, integrating it with particularly this kind of cancer with the health facilities already available in the system. I mean, in any program, since I worked with the Child Rights Commission, I know that any program where you can have a base support using the infrastructure already available, optimizing the resources, that definitely gives you a head-on start and a good solid platform to work on. So I thought that was a very interesting observation. How do we integrate this, bring about this integration? That is something I think that we really need to think about a little more and bring about. Thank you so much for this.
Thank you, ma'am. So let me once again thank the chief guest, Dr. Shobha Koshi ma'am, and also the speaker of the day, Dr. Santosh, who gave us a insight into the early warning signs of head and neck cancers and about the early detection and the tests for that. And Dr. Jayakrishnan from Community Oncology, who gave his perspectives, and he is closely working with the Kerala Cancer Crusade and the Cancer Literacy Mission to implement it in the 8-year project. and to have NCD clinics, the non-communicable disease clinics, rather than creating the fear of eco-friendly NCD clinic is a concept that Dr. J. Krishnan wants to promote. It is because people have got a fear of cancers. The moment you say the cancer screening clinic, right, Dr. Sandosh rightly pointed out, people may not come, but it is eco-friendly or a patient-friendly NCD clinic to detect for high-risk groups, and that from there we can pick up those high-risk groups who needs workup, diagnostic workup for cancers. And of course, this Kerala government's initiatives on Shaili app with the help of ASHA workers, they're collecting data. They've almost collected 50% data of the population right now, and by the end of this year, they will be covering a whole of 3.5 crores of Kerala population. The house visits are being done by the ASHA workers, and they've got a questionnaire that is app-based questionnaire that they're trying to get. They're trying to get data on the high-risk groups for cancers, including head and neck cancer, CA cervix, as well the CA breast, etc. And also the the risk factors like diabetes, hypertension, and all those things are being covered. But essentially, we need to spread this message that cancer detected early is curable. Yesterday, we had a session on cancer cervix, which session is giving us a rare insight into the cancers cancers can be eradicated. Cancer cervix is something that can be eradicated. What smallpox eradication did to the infectious diseases or communicable diseases in 70s or 80s, that is maybe CA cervix with the cancer vaccination, HPV cancer vaccination, is going to give this message that cancer can be eradicated. Some of the cancers can be eradicated, and most of the cancers, if detected early, can be cured. That's the kind of positive message that we would like to give in the Kerala Cancer Crusade and the Cancer Literacy Mission, and also to encourage all stakeholders involved in cancer in the primary level as well as secondary level and the tertiary level for early screening protocols that has to be integrated and practiced by all doctors, all specialists and also to train volunteers to look for high-risk group stratification. And that is something that we have to focus on, because if we truly wants to cover the large sections of population, we need to integrate. We have different strategies to make it happen. So with that message, let me thank all the speakers and the panelists. Dr. Diva Shah has come has joined us from Ahmedabad, and she has given us perspectives on head and neck cancers and the facts and figures from Ahmedabad too. She is a young, dynamic radiologist, and my association with her goes back to we are both executive committee members of the Indian Society of Gastrointestinal Abdominal Radiology, where she is doing commendable work there. Thank you, Diva, for joining. Thank you, Dr. J. Krishnan. And thank you, Dr. Sandosh, for joining us on this Kerala Cancer Crusade. We will be having the next session on October 18th. That is an international speaker, Professor Eng Kwan Hung, who is emeritus professor from the University of Malaya, joining us for the update on diagnosis of breast cancer. And he is a Mary Sklodowsky Award winner and a Merdeka Award winner from Malaysia, who will be talking to us, who will be giving us his insights on the breast cancer update. He's a pathologist as well as a physicist and has made commendable contribution in this field. So don't miss out. Let me remind you that date, October 18th, that the session will be a little early to suit the time zones of Malaysia. That will be starting at 6 p.m. on October 18th. So till then, thank you all and good night.
Thank you. Good night.
Good night.